Dr. Shaham, thank you so much for coming on today. I mentioned before you came on that this is something that I'm super excited about because I think your specialty has got a lot of popularity because of various maybe TV shows, rightly or wrongly. So I suppose a good place to start would be to talk a bit about you and what the specialty is.
Yeah, absolutely. Thank you for having me on. It's a pleasure to meet you. I've been following your videos for a while. I agree. I think so. True crime is just huge right now. There seems to be a Netflix documentary like every other week, and psychology has always been popular. So yeah, the intersection of that. So a forensic psychiatrist is somebody who assesses mentally disordered offenders. So you'll know this, but for your viewers, a psychiatrist is a medical doctor that deals with mental illness. A forensic psychiatrist does that, but specifically with people who who are potentially dangerous or violent. So I will assess people in courts or in prisons or in psychiatric units. There are different kind of areas that we work in, physical locations. So I've previously worked in prisons. I've previously worked in these secure units, and I've worked inside courts. But right now I specialize just as an expert witness. So I'm the guy that gives evidence in criminal trials.
Oh, cool. What made you pick forensic psychiatry? Because I know, because I'm guessing it's like a general pathway. You do psychiatry, general psychiatry first, right? And then is that correct? And then you subspecialize. But what was it about, I guess, forensics that interests you the most?
Yeah. So you're absolutely right. So when you go onto a psychiatry training course, you do 6 months placements. I'm sure you must have done something similar as a GP. So you go around different types of units. And I'll be honest with you, Asif, I didn't really even know anything about forensics because it's obviously because it's only the psychiatric wards are only for the most dangerous people. So there's not a big number of them. There's something along the lines of 80 units across the whole of the UK, whereas there's several hundred general adult psychiatry units. So I knew nothing about it. And almost as a whim, while I was waiting to become a registrar, my very last placement was in a medium secure unit in North London. And I just thought, I don't know anything about this. I was just a bit intrigued. And I fell in love with it immediately. So there were something like 18 men there. It was a male ward. And of that, something like 14 had killed somebody in the past. And that in itself is fascinating, but you get to learn about them and their backgrounds and obviously the offense itself, but you get to know them intimately because their pathway is so complicated and they're so risky that they're in hospital for a very long time, like, 2-3 years, sometimes even longer. So you see them on a daily basis, you know everything about their backgrounds. And to me, the reason I got into it is because you get to piece together what went wrong in their life. So what made them end up with a serious mental illness and what made them end up becoming violent. And often there's like confounding factors that describe or explain both of those things.
Well, okay, there's a lot to unpack there because I guess you kind of, you touched upon a lot of things I want to discuss. But I suppose it's like a broad overview. What kind of conditions would you see on a day-to-day basis, or what are the common kind of stuff that comes in?
Yeah. So I would say that there's a large number of people with a psychotic disorder like schizophrenia. So I suppose if I was going to simplify it, there's a spectrum, right? So one end of the spectrum, you've got pure mental illness. So you've got people with something like schizophrenia who committed serious violence because they had like paranoid delusions, or they were hearing voices that told them, and they felt like they had to act violently on those voices. That's one end of the spectrum. And that's, I don't know if simple is the right word, but it's quite clear cut what needs to be done. You treat the voices, you give the right antipsychotics, and you take away the violence. And the other end of the spectrum, you've got personality disorders. So the one that I would see more commonly would be antisocial personality disorder, right? So that is people who lack empathy, who are quite impulsive by their very nature, who don't really learn from their mistakes, who don't care about the well-being of other people. And they are completely in control of their actions, unlike somebody with schizophrenia. Okay. And they tend to be career criminals and just violent, nasty thugs. So you get that on the other end of the spectrum. Of course, everything in the middle, which makes it more complicated because it's harder to treat a personality disorder than it is for a psychosis.
So personality disorders is one of those things I guess it's thrown around a lot, right? This person's got a personality disorder, but it's a bit more complicated, right? Because you mentioned antisocial, which is one type, if I'm not mistaken. But I think another one that's thrown around a lot on social media is a narcissistic personality disorder. But there's quite a lot, right? Am I mistaken? There's tens of personality disorders, like there's tens and tens of them, right?
Yeah, I'd say there's in terms of the common one, there's probably about a dozen altogether. So we've already said narcissistic, we've already said antisocial. Borderline personality disorder tends to be one that is just got quite a lot of attention. I do see it in forensic and violent people sometimes. Then there's ones that I have studied about as a psychiatrist, but I almost never see. So things like dependent personality disorder or anancastic, which is when somebody's kind of like very, very obsessive. So yeah, there are something like a dozen different ones. Just for your viewers, the definition of a personality disorder as opposed to a mental illness would be that it's ingrained in you. So it's your personality traits. It's not something that's like an episode of mental illness like depression or schizophrenia or bipolar. It's actually a description of who you are as a person. And by definition, if you struggle to function in relationships, in work or in everyday life because of your personality disorder, because you're argumentative or because you're so anxious or whatever it is, but it's your personality, then by definition, that's a personality disorder.
And how do you diagnose that? Because it can be quite tricky, right? Because what you just mentioned, how can how can it be like a normal thing as opposed to a diagnosable condition that needs, and then the second part is who needs to be treated.
Yeah, so only a very small proportion of people with the personality disorder will believe that there's something wrong with them or something that needs treatment. So that's the first hurdle, is actually getting people to present in the first place, because depending on the actual personality disorder, a lot of them don't have insight. So if you're antisocial, you don't want to be fixed because this is you and this is your lifestyle. But there are ways of defining it. Like everything in medicine, there are categories. We use the ICD, DSM. I'm sure you've heard of these categorical systems. So if you have enough of the features, then you lack functioning, then you have personality disorders. I mean, they can definitely be addressed and they can be treated, and there is therapy. So to be specific, you get something like dialectical behavioral therapy, which is mostly used for borderline personality disorder. So therapy does exist, but the problem is getting people there in the first place, thinking that they need help. And also because you're literally unlearning patterns of behavior that are ingrained and lifelong. So it's not an easy fix. Months, if not years, to actually get people to reflect on their own interactions and try and change things.
So it's interesting because, so is it true to say that are you born with a personality disorder and it just is like a switch or a genetic factor, or is there like an environmental factor that, and in some cases, can someone live their whole life with a potential personality disorder that's never kind of triggered? Is that a way to look at it, or is it something that does always eventually come out? It just takes longer in others, or is it something that someone? And also, did it happen? From what age is common for it to get diagnosed?
Yeah. So technically speaking, you can't get a personality disorder until you're 18 years old, because technically speaking, your personality hasn't fully developed until you're 18. Although you can have traits of some personality disorders when you're a teenager or when you're younger. And I suppose there's no such thing as a hidden personality disorder. What I mean by that is it's not just having the traits, it's also affecting your functioning. So if you're functioning well, if you're getting on with people in general, and if you're holding down a job and a family life, etc., then you might have some of the traits, but then you don't actually have the disorder because it's not affecting your functioning. Almost by definition, you need this change in your functioning. And I think people get confused because you can have traits but not have the diagnosis. So, for example, psychopathy, which I'm sure is something we'll talk about. Lots of people say that this person is a psychopath because, A, B, and C, because he's charming, because he lacks empathy. That's just traits of psychopathy. You have to have a certain amount, and it has to affect your interactions for it to be an actual diagnosis of a personality disorder. So to summarize, I don't think you can have one that isn't triggered, because to get the diagnosis, it has to be triggered. But you can certainly have people that go through crises. So borderline personality disorder is a perfect example of this. You can have somebody who has those features. So for your viewers, they're things like an unstable mood, like an explosion of anger and arguments at times, this feeling of this fear of being abandoned, self-harming, substance abuse. All of these things are features, but that doesn't mean they're always there all the time. You can have periods where you're very stable and function absolutely fine, and then there's a crisis, whether that's like a tragedy in the family or a breaking up of a relationship, whatever it is. A crisis can cause somebody to deteriorate for a few months at a time, hopefully get better. So my point is that the personality disorder is always there, but the way that it presents can fluctuate.
Oh, interesting. Now, what are the kind of telltale signs of someone having for example, like a personality disorder? Because I'm sure, like you just mentioned some there, but borderline personality disorder. But if anyone listening, if they think they may know someone, because I guess a lot of the time it's maybe family members or friends, I notice it first. Okay, this is a bit different. What are some of the telltale things, or even some of the? I guess a good way to put it, what would be this almost subtle signs that someone might have something serious going on?
Yeah. I suppose if we're talking about it in general, right? So personality disorders in general, then like I was saying before, is if they can't function around other people, right? So if you've got a friend that's fallen out with their partner, neighbor, friend, there's nothing wrong with that, right? If they're falling out with 2 or 3 different people, then, you're wondering what's going on. If they're falling out with lots of people regularly on a regular basis and they just can't maintain a relationship, even if they don't recognize it's their fault, then you've got to start thinking, logically, is there something wrong with them and their interactions?
Yeah.
Or rather than everybody else that they're beefing with, right?
Yeah.
So I would say that is the telltale sign of a personality disorder, in that there's an individual that that just can't relate to people in general. So you might have somebody that for whatever reason you don't get on with, but that doesn't mean that either of you's got a personality disorder. It's when it's like almost all interactions with everything. That's my general answer. Obviously, for the specific personality disorders, it depends on what it is. So I'll be specific. So something like narcissistic personality disorder, which we haven't talked about yet. So that is when somebody is just got a massive ego, basically a heightened self-inflation, and they just do anything for attention. They love adoration. They cannot handle criticism. So a telltale sign of that would be if you've got a friend who doesn't feel like a great friend, so when there's a drama, when they've got a drama, they always suck you into their drama. They always need to be the center of attention. If you've got a problem, then you're kind of sidelined and dismissed, and it always becomes about them. So that would be a specific telltale sign specifically for narcissistic personality disorder.
And that's an interesting one, because I get, someone being a narcissist and it being a personality disorder. Is there a difference?
Yeah. So narcissist is you have some of the traits of narcissistic personality disorder.
Okay. Yeah.
Right?
It goes back to what you saying earlier.
Yeah, exactly. But if you've actually got the PD, the personality disorder, then you're struggling. So you're such a narcissist that people, like if you work in media, for example, people don't want to work with you. People, maybe you can hold down a job, but maybe people just stay away from you because they just don't want to be sucked into the drama. Maybe you've struggled with romantic relationships and you've broken up with loads of people because it's always about you. Or maybe you've got a normal relationship, you've got kids, and your kids don't feel they can confide in you because, again, it's all about you. You take all the drama. So there's a difference between being narcissistic and actually having the personality disorder.
I suppose what you described can also often describe high-powered people like CEOs or company owners or whatever it may be. So what generally, I know it's hard to say, but is there a specific cohort that gets this more than another type of cohort? Or I'm saying specifically to occupation or ethnicity or gender or anything like that?
Yeah, absolutely. So we could talk about psychopathy because it's just a bit sexy and a bit more interesting than narcissism, although there's a huge, huge overlap. So narcissism is when everything I described before, like is huge, there's a inflated ego. A psychopathy is like that, but the difference is the psychopaths are also really manipulative. A narcissist, wants the love and attention, but they won't hurt other people. I don't mean necessarily physically hurt. I mean like manipulate other people emotionally, for example. They won't do that because they're not that way wired. Whereas a psychopath is narcissistic, but is also really manipulative and deceptive, but they're also really, really charming, right? So a good psychopath is not obviously a psychopath when you first meet them the first few times because you just think, what a cool, nice man or woman. But then they will draw you in and they'll use you for something. So that's just a bit of background. But to answer your question, absolutely. So they're massively represented in the media, as you probably guessed, because they want to be the center of attention. And as you'll know, there's a lot of competition in the media. There's a lot of peers. There's, it's a very crowded space. So a psychopath might do something like, for example, lie about colleagues or make them feel bad about something, or like just do anything to stab them in the back to get up that hierarchy. And in the same way, CEOs, so within the corporate world, it's quite well established that not just people in the corporate world themselves, but the people at the very top, CEOs. I'm not saying for a second that all of them are psychopaths, but you can see why if you had those traits, if you just didn't care about who you stabbed in the back, all of your peers that you might betray to get there at the top, you make deals which might crush other companies or might, damage the business or the company of other people that you've worked with, but you don't care. You just do whatever it takes to get up that ladder. Then having those traits can be helpful. And also, I think another trait of psychopathy is a lack of fear. So being able to stay calm under pressure. So for obvious reasons, that would help in occupations like being a surgeon or being a first responder, being a soldier. That'd be a great one, or being a spy. So anything where you're under threat, but you're able to just basically keep calm and not get anxious.
So I guess a psychopath essentially is someone who's got narcissistic traits, but potentially can be quite dangerous. I think, can someone who's got psychopathy or a psychopath become violent? Is that a common theme, or is that is that something that they can control as well? Because they, like I said, they're charming, they can do what they want to kind of get you to do things.
Yeah. So absolutely, a lot of psychopaths are violent, but they don't have to be. So they're violent. From my experience, I've worked with loads of loads of people. I've worked with something like 20 people that have been officially diagnosed with psychopathy, and probably about 100 more that I think haven't been formally diagnosed because they've never just gone through the test, but I think have psychopathy, or at least have a lot of the traits. And to answer your question, it basically, they use violence if it helps their situation, right? So if you're say you grew up in a rough neighborhood and the people around you are drug dealers, and you decide, I want to be a drug dealer because that's a good way to make money, then, and you're a psychopath, then using violence absolutely will work in your favor, right? Because that's how you discipline your minions, or that's how you intimidate your ops. Whereas if you worked in the corporate world and you're a psychopath, there's no benefit of being violent. If anything, it could get you in trouble. It can get you arrested and you can end up going to prison. So psychopaths are violent and can be violent, and they don't care about violence. They don't care about who they're hurting, but also crafty enough to only use it when it's in their favor.
Okay, so super interesting actually is around the psychopaths and how they can almost manipulate what they're doing and their actions and their thoughts. And I guess the question comes to diagnosis, because if they, as you're saying, they can be quite crafty and very clever. Should they so wish, they could almost skirt around a diagnosis, right? Because they may well know, okay, if I say this will trigger a diagnosis. I'm guessing they can be quite hard to diagnose.
Yeah. So I'd split them into two groups. There is the people who are psychopaths who are out in the community and functioning relatively well, which is a very large group. And they will probably fly under the radar because there's no reason for them to get assessed. There's no reason for them to come into contact with mental health services or forensic services, such as what I work for. And then you've got a much smaller proportion who do get in trouble. So even though they're good at controlling their emotions, they still get into fights, they still get arrested, and they end up in prison. And because it's quite hard to spot, I don't think they're often picked up straight away. But if they keep going through the system over and over again, getting out of prison, going in and out of psych wards for other personality disorders, then it becomes apparent. So if it's helpful, I'll tell you a very quick story of a previous patient of mine who is a psychopath. So I remember I was just it's my first ever job as a registrar when I was in forensics. I was in this therapeutic community. So just very quickly, it is a locked psychiatric ward, but it's slightly different because most people aren't there on medication. They're there just for intense psychological therapy, which basically happens 24 hours a day. So everything you do is kind of psychoanalyzed and fed back. And the way you interact with the other people on the ward, you have like these regular meetings and you talk about your feelings and you talk about interactions and triggers in public in front of everybody. And then you also have regular sessions like one-to-one with your psychiatrist. But anyway, so that's just the setting is quite an unusual thing. There's only a handful of units in the country. But anyway, I remember on my very first job, there was this man, I'll call him Mr. P, to protect his identity. But I just remember he stood out because couldn't tell what was wrong with him. Like on the surface, he seemed very normal, very charming. I actually honestly thought he was a member of staff at the beginning because part of the therapeutic community is that the staff and the patients kind of interact and mingle. So we have, lunch together, for example. So you don't wear uniforms. So everybody's dressed kind of the same. And obviously staff wear like staff badges and alarms, but everyone looks the same. So it actually took me a couple of shifts to realize that he was a patient and not a staff member. And I interacted with him for a few weeks and he just seems... So I knew his background story and he'd done some pretty violent things in the past. He actually tortured a man for several hours, which is how he ended up in our ward in the first place. But he answered everything absolutely perfectly. Like there was he didn't lose his temper at all. So within this ward, a bit like you'd expect in prison, and a lot of people came from prison, you had your hierarchies, you had your beefs, you had these cliques of guys that stuck together and there's a bit of bullying and exactly what you'd expect on this kind of ward. But this guy, Mr. P, he was kind of everybody's friend. Nobody disliked him in terms of the patients, but he didn't really have any alliances, which in retrospect is part of his psychopathy as well, because he knew that it would help his progress to not be like too pally with anybody, especially people that got into trouble. But anyway, the conclusion of the story is that I was going through his paperwork and stuff like that for his CPA, for his regular meetings, and he was due to be on the ward for a couple of years. And he got unescorted leave, which was a very slow process. Like it took 3 or 4 years for him to get that in the first place. And he'd never breached a boundary, never got into a fight, never got into any trouble. So eventually the doctors trusted him enough to get unescorted leave. And he basically vanished. So he'd planned it all along to just kind of go under the radar. And he went on the run. So he got a train, went up north somewhere. He eventually did get found, but many, many months later, like 5 or 6 months later, by which time I moved on to another placement. But my point being is that if I had to pick of everybody that's on the ward, he was the most stable and the one that had the least interruptions, didn't lose his temper, didn't have problems, passed all the assessments, but he's the one that escaped. So that really reflects what a psychopath is. They're very, very cunning and manipulative.
I'm going to put you this question because I guess the American election's been in the news a lot recently, right? And obviously, Donald Trump. So a lot of the characteristics you say, and especially what he's been through, the assassination attempt, with the lawsuits, yet, he would go to like a rally the next day and do like a speech, and he almost says what you want to hear. Now,
Is he a psychopath? That's your question.
yeah.
Okay,
what do you think? Yeah, because he's a very interesting character, isn't he? I'd love your opinion on him. What do you think of him?
As long as they get put on some kind of hit list from his fans. You know what? So I have thought about this, and I've been asked this in interviews in the past, when he first came to power many years ago. And my answer back then, and it might have changed, I'll come on to that. My answer back then was, I think he's definitely got some of the traits of a psychopath, because he clearly lacks empathy. He's clearly willing to do whatever it takes to advance himself. So to be specific, he's friends with somebody, another politician, 1 minute, and then he's really, really rude and insults them, and then tries to become friends with them again. So he doesn't seem like he cares about other people's feelings. So he lacks empathy. He said some pretty nasty things about groups of people, which again reflects that he lacks empathy. I suppose you could say he's manipulative. I think he's a bit clumsy with it, but he is, manipulative, making up lies about, losing elections, knowing that other people will fight on his behalf. The one thing that falls for me about him is being charismatic. So I personally don't believe that Donald Trump is charismatic. And almost by definition, a psychopath is so good at what they do that they're really good at hiding their manipulation. Whereas I think he wears his manipulation on his sleeve. Having said all of that, the fact that he's now won and he's got the majority vote either means that I'm right and he's not charming and American people are hoodwinked, or he is charming, just his charm doesn't work on me and I'm the one that's wrong and I'm the naive one, and he is actually charming just, for the masses of people. So I don't know what to decide of those two categories. To summarize, I don't think he's charming, but he has charmed half a nation, so maybe I'm wrong.
I think he's quite
I'm
charming.
going to ask you, Asif, what do you think? From what we've been talking about?
I agree with everything you said, but on the contrary, I think he's quite charming, actually. So I think he just, and also I've never seen him live or anything like that, but I can imagine if you ever saw him live or were in a room with him or an environment, I think he'd be so influential and you'd almost get swayed away with just his presence. Yeah, so whether he's psychopath or not, I think going by what you said, I think he probably fits the criteria. Or everything he's done has had. I know you say you think he's quite clumsy with it, which I think is true, but I think he knows in a way that is something that makes him different. Like almost saying that what I say is what I mean, and he kind of knows that's what the majority of people want to hear. So I think he's very clever with it, and I think he is very charming, especially in real life. So I think he potentially is, but I don't want to say, I mean, wrong, because
he's certainly narcissistic, isn't he? I mean, he clearly says, I'm the best and this is the best and our thing is the best and all my opponents are rubbish. So he's definitely narcissistic. I suppose when I'm talking about his charm, like he's very combative. And to me personally, I think that almost negates charm. But again, maybe I'm wrong. Maybe people do find that charming. I don't know.
Well, he's definitely very interesting. Now he's won now, so you have to see what happens. But another term that gets thrown around is a sociopath, right? And even me, I get confused between the sociopath and psychopath. Is there a difference, and what is the difference?
Yeah, so I suppose psychopath is a clinical term that we use in forensic psychiatry. We've got an actual psychopath test so you can measure how many different traits an individual's got and how much of each of those traits. So if you asked 100 forensic psychiatrists what is a psychopath, they will pretty much give you the same answer. Whereas sociopath is a very vague term. It's kind of social term, by which I mean it's defined differently by different people. If you asked 100 whatever experts there would be what sociopath is, they might give you slightly different results. It's less well defined. But generally speaking, it's sort of that a psychopath's better at hiding their intentions. So they live normal lives. They will hold down jobs, they will have positions of power potentially, whereas sociopaths tend to live on the fringes of society. So sociopaths might be like your drug dealers or your gang leaders or the people that, are on the other side of the law. And also they say that sociopaths can't control their temper as much, so they're much more reactive. So if you pee off a psychopath, then he might not react, but he'll remember and he will he will plan his revenge and it will be a dish served cold. Whereas if you annoy a sociopath, they will react because they can't help it. A bit like some of the personality disorders we were talking about, like borderline, it's in their nature to get angry easily. And also, they say that sociopaths have a little bit of empathy. So despite the fact that they can be quite explosive, they have some empathy towards some people, whereas a psychopath typically doesn't have any empathy, even towards people that they know and supposedly love. So a psychopath can be married, they can have kids, and they can show them affection, but deep down, if it came down to it, they wouldn't sacrifice because they're psychopaths.
I don't speak to the answers, but do we know why? What causes a psychopath or a sociopath? What is it like? Is it genetics? Is it if your parents have it, you have it? Like, it's probably a very hard question to answer. And is there any studies on like, brain changes, actual MRI physical changes in the brain?
Yeah, I can answer
Really
that. So
to know.
I suppose, like everything to do with psychiatry, the answer is always nature and nurture rather than one versus the other, right? So if we're talking about nature, so that's like what you were talking about, so like chemical differences or brain structure, we know that if you measure the brain of psychopaths with MRIs, they have reduced connectivity between the amygdala and the ventromedial prefrontal cortex. I'm sure that sounds like a lot of jargon to your viewers, but basically the amygdala is a specific area in the brain that's involved in processing emotions, and the ventromedial cortex is involved in decision-making and regulating emotions as well. So there's reduced connectivity between these two regions, and that is said to lead to or contribute to a lack of empathy and a lack of remorse. Now, the reason that I don't like talking about brain scan studies is firstly, they're impractical. You can't, brain scan everybody that comes in or that you suspect of being a psychopath. It's just unrealistic, number one. Number two, there's so much variability anyway that the sensitivity of that is quite low. So another way of saying that is that the variety of normal people's amygdalas is enough that it can throw off the results. But ultimately, I think there are some brain changes that are recognized in psychopaths. To me, what's much more interesting and much more tangible, and something that as a forensic psychiatrist we can address, is the nurture. So it's about the environment and the childhood, right? So childhood experiences that might encourage somebody who already has these brain changes to become a psychopath would be things like you'd expect. So it'd be like abuse, neglect, very harsh parenting, whether that's physical, sexual, emotional abuse. And then that would be your background historical factors. And in terms of the current factors, that would be, your situation. So if you're in a situation where you can manipulate other people, if you've got access to potential victims, and you have these traits, then you're more likely to use them.
Interesting. Now, this is a common kind of thing a lot of people say, and whether, if cruelty towards animals or harming animals when you're a child, does that correlate at all to becoming a psychopath when you're older?
Not really, no. So there used to be this theory called the McDonald triad, which was if you tortured animals, if you set fires as a kid, and if you wet the bed, then that would increase your chance of becoming a murderer or a psychopath in the future. And it was a theory that was made by an American psychologist, I believe, maybe in the 1950s, something like that. And it stuck around for a while, but it's all BS, to be honest with you. There's no studies that show any of that's true. I think you could quite reasonably say that if you torture animals as a kid regularly, then you lack empathy. And that obviously is one of the key features of psychopathy. But it doesn't necessarily make you charming or manipulative. You could hurt people or want to hurt people or not care about other people's well-being. But if you're not charming and you're not manipulative, then you're not a psychopath. You're antisocial maybe, but you're not a psychopath.
If you stop it developing, say if you see a child, you maybe have a lot of the signs and symptoms of becoming a psychopath. Is there anything you can do to kind of almost halt it? Is that possible?
Yeah, like all kind of developing personality disorders, it's really difficult to reverse somebody that's so entrenched. But if you spot it early enough, you can absolutely. There's a couple of things you can do. First of all, you can decrease the other risk factors. So, drug and alcohol use is a huge risk factor. So, people who are predisposed to violence and aggression, if they become disinhibited with alcohol, for example, or drug addiction, then that massively it's probably the most important factor, I would say. So you could reduce that. So you can, try and steer them away from alcohol and drugs, or if they've got a problem, you can put them through rehabilitation. So that's one thing. Comorbid disorders such as depression, anxiety, which I'm sure you see a lot in your line of work. If you treat those things, then again, you're not changing their personality, but you're taking away the chances of them destabilizing. So that's the comorbid stuff. In terms of actually changing their personalities, I think you can. Again, it takes years and years of therapy, and you have to observe them very closely. and also just take them away from situations where they might offend. So, decrease their access to victims. Don't put them in situations where they might beat up people. So you can reduce the risks. I don't think you can change the core beliefs very easily, but you can certainly reduce the risks.
Now, one thing you mentioned about was diagnosing patients, and a lot of the time is, their psychopathy or being a sociopath is kind of comes to light, with a crisis, right? And I guess the point I'm alluding to is sectioning, and them getting sectioned for, I guess, an assessment and diagnosis. And there's still a lot of, stigma around being sectioned or misunderstanding, even amongst doctors. So if you could talk a bit about what actually sectioning is, and what are the kind of things someone has to be doing to be able to section them.
Yeah, absolutely. So when you section somebody, means you detain them against their will under the Mental Health Act. There are lots of different types of sections, but the common ones, the civil sections, would be Section 2 and Section 3. Like, as a forensic psychiatrist, there are special prison sections, but I won't go into that because they're not going to affect the average person. Right. So Section 2 is for assessment, which lasts for 28 days. So which means that at the end of the 28 days, your psychiatrist either has to discharge you and let you go, or you can stay on as a voluntary patient, or it's converted to a Section 3. And a Section 3 is up to 6 months. So at the end of that 6 months, they either have to renew that section for a longer period of time or discharge you, or you can be discharged earlier at any point. So that's, in a nutshell, what an actual section is. When you're sectioned, you can be treated against your will, especially if you're on the Section 3, and you can't leave hospital without the permission of the staff because you're deemed to be a danger. The one thing I would say, and I hope this reassures people, because it is a scary concept, I get that, but hopefully to reassure people, is that the medico-legal criteria are very, very strict, and there's a whole process that you have to go through. So I'll talk about what the criteria are, and then I'll talk about the process. So somebody has to have a recognizable mental disorder, and it has to either be affecting their safety, the safety of other people, or their mental health deteriorating. So, for example, if somebody is suicidal, that would be the most obvious one that would tick the box for safety. If somebody's hearing voices and is acting violently towards random strangers, that could affect their safety of other people. And if somebody needs some sort of medication and they're going to get worse and worse if they don't take that medication, that's their health deteriorating. So it has to tick at least one of those 3 boxes. And it has to be of a nature or degree that they need to be detained. So if they can be treated in the community, then by definition, it's not of a nature or degree that needs sectioning. So if it is something like low mood and it can be treated with antidepressants, or if it's a mild level of psychosis and there's no risk, then that also can be treated in the community. So you can't section somebody for those things. I would say that the threshold for somebody being sectioned is actually quite high. So again, popular to contrary belief, you have to be very, very unwell, which is good for the average patient because you don't want to be sectioned. But you could argue that it also makes it quite difficult because there's people who don't quite meet the threshold but are still really unwell. And unfortunately, there's very little that's kind of done. They often fall through the cracks. In terms of the actual process itself, so you need 2 independent doctors and 1 independent, what's called an AMP, an approved mental health practitioner. So that's usually a senior social worker. And when I say 2 independent doctors, that they can't work in the same hospital. And the point of that, I think, is so that it is independent. You don't just have one doctor who's pals with another who just signs the paperwork because they know each other. It has to be 2 independent doctors plus this senior social worker who's all 3 of whom are very well versed in the Mental Health Act, and they do an assessment, all 3 of them together, and there have to be a consensus. All 3 of them have to agree that somebody meets those very specific criteria. Okay. So that's how it works in practice. In theory, in practice, I have to say that, in my view, it's a very inefficient, a very clunky process. So what I mean by that is, say you've got a family member who you think's becoming really unwell, like say they're starting mumbling to themselves, they're hearing voices, and let's say, as might be typical in the psychosis, they're hiding knives, for example. So you're worried about them for good reason. The problem that I think with the process is you take them into A&E, then, as you know, A&E's backlogged, so you might not even get seen by a psychiatric doctor for 4 hours, maybe even longer than that, 6 hours. And then it's usually a junior psychiatric doctor who's not Section 12 approved. Section 12 approved is going through a process where you have the accreditation to use the Mental Health Act. So then they've got to phone their registrar who's on call, and that person might take another hour or 2 to get in. And then they have to phone the AMP that I was talking about. And if it's in the middle of the night especially, or if it's at a weekend, then the AMP has to find an independent doctor to come in. And honestly, I've seen this process take up to maybe 12, 14 hours altogether. And it is very hard to convince somebody who's unwell, who doesn't have insight, to stay in a hospital for that long. So you've got a problem there where it's just the process, in my view, is just far too long and clunky. So you get people that don't engage, or people that are quite paranoid and they'll just walk out. And so I don't think it's a great process.
Yeah, no, it's hard because in general practice, say if I see someone who I think may be suicidal, say right opposite you now, like you normally call that, like a liaison psychiatry team, which is not normally the doctor, it's normally a nurse trained in it. And then they normally have to try and escalate to the consultant who may be out doing assessments. So she's like, for instance, so what do you do with the patient, because do you keep them in there? And this can take a couple of hours, right? Because they're out, but then if you don't keep them in there, there's a risk of them, harming themselves. And then you have to trust on them if they've got no family members in particular. So I've always found that, and also I've always found that because as a GP, we can't section anyone, right? And so there's always that limit where a few times I've been right, okay, look, this person's at risk. And a lot of time I just get them to wait in the practice, right?
Yeah.
But there's always
it's fine if they want help. So if they are, like, take the example of something suicidal, if they acknowledge they've got a problem and they want help, then it's still the process. But you as a GP, at least you know that they're there and they're safe, and they might have to wait a long time, but at least they're there. The problem is when they don't want help. So if you're really suicidal, like you actually want to die, you don't want to get better, then that's a scary situation for everybody, because what's stopping them literally walking out?
Yeah, I actually did a psychiatry placement as a student, and it was amazing. It was really, I was really pleased to do it. But it can be a bit sort of unnerving at times because sometimes when you look at patients who've got schizophrenia or a psychopath and have done bad things and are who have been sectioned, when they come in for assessment, sometimes it's just you and the patient, because a lot of time it's me, the consultant, and the patient. And it can not be scary, but be a bit unnerving. Like, how do you find that? Because you must, dealing on a day-to-day basis. Like, do you ever feel like this is quite scary? Do you have like security there? Because, it's one of those things where potentially it can get quite dangerous, right?
Yeah, absolutely. So I would argue that the units that I work in are even more kind of anxiety provoking and potentially scary than your general adult psych wards, because everyone in there has a history of violence. You don't get in because the resources are so much more in forensic units and the patients stay in for so much longer. They're reserved for the higher risk patients. So you don't get in unless you've actually committed some very serious violence.
Yeah.
So the patient, and a lot of people come from prison. So absolutely everything you're talking about is true. I would say that we're geared up to handle violence better. So I'll be specific. So every staff member carries an alarm. We have these things called seclusion views, which I suppose is kind of connected to the antiquated idea of having a padded room. And it's not padded, but that's what people think a padded room is. That's what a seclusion room is. So patients are taken there under restraint if necessary, if they're so agitated that they're a danger to other people at that time. All the nursing staff, even the medical staff, were trained in restraint and handling and stuff like that. So all the doors are like double locked and there's an airlock. So it's built up for it's the whole place is designed to deal with violence, but of course that doesn't make it any less scary. It can be tense. Yeah, you have to be very aware of your surroundings. Every time you go on a ward, the very first thing you should do, even if you're a regular doctor on there, is go up to the nursing staff and ask them, are things safe? Who do I need to look out for? Is there anything I need to know? But I'll be honest with you, I got my very, very first time in a forensic psychiatry unit. I got punched in the face by a patient.
What happened? You just got angry at you?
Yeah, so it was a very strange thing. So I was an SHO. You remember how I said my very last placement before I became a registrar was in forensic. So it's on the first day of that placement in North London. And it was bizarre because the guy, I didn't even speak to the guy. So I was basically trying to show off. So I got in really early in the morning on my very first day, and I thought I'd interview a few patients so I could, feed back in my ward round, which I didn't really need to do, to be honest. But and whilst I was there talking to the patients on my team for the consultants I was working with, the man that punched me seemed really preoccupied with me, and he wasn't in any way aggressive, and he was completely psychotic. But he was like looking at me really strangely, and every time I left the interview room, he'd ask me these really bizarre questions, but they weren't like aggressive questions. They were just like, he believed that I was somebody else from his past. So he kept asking me about what school I went to, and he kept telling me that we were in a cricket match together. And I just I was a bit dismissive. I brushed him off. But I think he delusionally thought I was somebody else from his past that had come to spy on him. And then I just walked out of the room, and he ran out behind me and just punched me as hard as he could on the side of the head. Literally didn't see it coming. It's from the side. I lost consciousness for a couple of seconds, and then he got restrained and taken away. And the honest truth is, Asif, I didn't really, because there was no build up of danger, because it happened so quickly, I didn't feel any fear, not because I'm incredibly brave, but because literally I didn't see it happening. So by the time I realized it was happened, I woke up on the floor unconscious. I don't remember being hit.
God,
And the guy had already been taken away.
yeah.
So it was very surreal for me. But I also know that it was completely because of his mental illness. You know, he had schizoaffective disorder. It wasn't personal, so it didn't really bother me, if I'm being honest.
I know you can't talk specifics, but leading on from that, has there been any cases or patients that stick with you for various reasons, whether because they've been exceptionally either brutal or if they're, even if they were a patient that treated, turned because you treated them really well? Is there any particular cases that you remember for any reason?
Yeah, absolutely. Unfortunately, just going that point that you asked in the question, because they've done particularly well. Unfortunately, it's a bit of a thankless job. And the reason I say that is because patients are the patients we see are the most damaged. They take the longest to rehabilitate. And in a slight irony, once they get well enough to no longer need forensics, they move on to another service. So we don't even see them get better. We see them get better to the point of discharge, but not beyond that. So if somebody's deemed to who has been violent in the past, could have been a high level of violence, could have even been like murder. If they're deemed to have been stable in the community for whatever, 6 months, a year, then they're discharged to the general adult service. And if they're even more stable, they're eventually discharged to their GP. So I suppose the point I'm trying to make is we never actually see them at the other end when they come out well. Unfortunately, that's just the kind of a quirk in the job. But to answer your question, the one that definitely stands out the most to me, and I've actually written a book about my professional memoirs, quick plug there. It's called In Two Minds, and I talk about her extensively, is a girl who in the book I call Yasmin. That's not her real name. And she was 18 years old and she didn't have any kind of history of psychosis, no antisocial behavior at all, never got into trouble at school. She was like a model patient. In fact, she was going to be a medical student. She'd applied to do medicine. And over the space of a couple of weeks, she suddenly became psychotic and she smothered and killed her nephew. So her 3-year-old nephew, just completely unexpected. But she believed that he had demons inside of him and that she was rescuing him, saving his life by getting rid of these demons, and that she could reincarnate him later on that evening with the full moon. And as a reflection of her odd belief, she didn't even try and cover it up. So she just went around her normal day. So she was babysitting this kid, and then her mum, so the kid's grandmother came, obviously, got really agitated. And Yasmin, this girl, didn't understand. So in her mind, she was like, I don't understand why you're shouting. I'm going to reincarnate him. Again, I'm just saying this because it really reflects that she wasn't like an evil, hostile, antisocial person that wanted to harm this baby. She didn't understand what she'd done. So she got remanded to Holloway Prison, which is now defunct, but I assessed her there. And I was a registrar at the time. One of my first cases, as the first time I gave evidence at the Old Bailey. And it was really hard to assess her because she was very guarded. She wouldn't talk about what happened at all. And she would just make these really weird, slightly religious kind of things like God will understand and things like that. So she wouldn't address any of the symptoms, but she made vague statements that made me question her mental state. So upon my evidence, she went to hospital on a remand order, section 48, instead of being charged for a life sentence, which is what the prosecution wanted. And she got treated over many years in this medium secure unit. I worked there for a time, then I had to move on with my other placements. And it took a long time to treat her. And it took about 18 months before she even accepted what she did. So for 18 months, despite all these medications we were giving her, she remained psychotic. So she didn't believe what she'd done. She didn't believe that she killed this boy. She believed that he'd been reincarnated. And then, as you'd expect, 18 months later, when finally her psychosis resolved, she had this like huge wave, this tsunami of guilt, which we also had to treat. So I suppose to me, it stands out for so many reasons. I mean, the most obvious reason is just the tragic nature of it all. It was very, very scary for me to give evidence at the Old Bailey in a criminal trial. I'm very used to it now because I've done it dozens of times since then, but that was my very first time. And just this kind of tragedy of it all, seeing her deal with the aftermath of it. And then the other bit I forgot to mention was that her brother, so the father of this child, would come in on a weekly basis, not near the beginning, but towards the end. And I would be in the room when we were doing this like family therapy to try and heal like their relationship. And he had to forgive her basically. And it was just really painful to watch the whole thing.
There's a few interesting points. I guess one is in the murder case specifically, people may be aware, especially if they haven't got a true condition, that if I cite, psychosis or schizophrenia or hearing voices telling them to do it, they can almost get off the hook for a life sentence, for example. So obviously your assessment in that is crucial, right? It's life changing. It's essentially almost sending someone to life in prison or a rehab kind of placement. And going back to when you were saying psychopaths can be very manipulative and, you know, to say things they get they want, how do you even start? Where do you start with that? With such a heavy, where the outcome is so severe potentially if you get it wrong.
Yeah. So that's a very good question. I suppose I would say that the threshold to get a psychiatric defense and to go to these units like Yasmin, like that story, the threshold's really high. So you can't just have some symptoms of mental illness. You have to, upon the evidence of a forensic psychiatrist such as myself, you have to prove, like, there has to be an established mental illness, and you have to prove that they were suffering from symptoms at that time. So Yasmin's case, for example, there were lots of witness statements about her behavior in the weeks leading up to this, and she made lots of bizarre statements. Her neighbors had very strange conversations with her, which didn't make sense. Even at the police station, she was doing she was saying some really strange things. Even on the psychiatric ward, there were other kind of strange things about her, like she wet herself at one point and then didn't tell anybody while she was in the police station. So I suppose what I'm saying is you don't just take the person's word for it. You look at all of the evidence, you look at all of their background, you look at psychiatric reports, especially for a murder case. You're expected to go through these things with a fine-tooth comb. So you need to seek some consistency, not just how they were at the time of the offence, but the police interview transcripts, CCTV footage, any witness statements. That's one thing I'd say. The other thing I'd say is that it's actually really easy to spot somebody, I think, who's faking it because they're just not very good at it. So I'm sure you, in your line as GP, you must have met some psychotic patients in the past. And those who are truly psychotic are very guarded, right? So if somebody comes in saying, I'm hearing voices, doctor, or looks around, if they're overacting, then I'm really suspicious. Doesn't mean automatically that they're faking it, but I'm very suspicious. If they try and convince me, if they have an agenda that they want to get into hospital, then I'm very suspicious. People who are truly psychotic, from my experience, which is very, very small proportions, probably 1 to 5% of the cases I see is very, very small proportion. They're very guarded, and they don't want to talk to you because if they're paranoid, they're not going to just open up to some pump in a waistcoat they've never met before. They're actually, they see me as part of the system. So it's the ones that don't tell me anything. If you chip away, then you finally get some psychotic beliefs. Those are the ones that are truly psychotic. Whereas the ones that overact are like, dribbling wrecks that are looking around and going, they look like what Hollywood would make a mentally ill person look like, not what a real mentally ill person looks like.
That's interesting. I guess that's from experience as well, but also it's interesting about saying gathering evidence, because I was always under the impression if someone says I was hearing voices, how can you prove that? But I guess all those witness statements you're saying, looking at the whole picture, otherwise it'd be too easy for someone to say that, right?
Yeah. And then for the small proportion of cases when you're not sure, you can use a remand order, which is what happened with Yasmin, because even though I thought she was ill, it was really hard to actually get her to tell us what she was thinking. So it's hard to have anything solid or tangible that was a psychotic belief. So she's a perfect example. So you can have a remand order, which lasts 3 months initially, and then you can add a month onto it, and the trial gets delayed by a month for a maximum of a year. So in those very small cases where you're not sure, you can actually observe somebody on a nursing in one of these units before their trial, and it's relatively easy, I would say, to try and fake hearing voices for an hour when you're speaking to a psychiatrist, but it's pretty hard, I'd say, to do that for an entire year if you're in a psychiatry unit. And are there people that fall through the gap? Not to my knowledge, but it's not unfeasible that there are. But also the other thing that's really important to remember is that psychiatric admissions are not necessarily shorter than the equivalent prison sentence. And in fact, if somebody's chronically mentally unwell, there's been cases that I've been involved in where they're longer. So you actually end up staying in the psychiatric unit for longer than you would have as an equivalent prison sentence.
Wow, interesting. Now, this is interesting because we mentioned about, crime documentaries and crime stories, and, I love watching, Netflix on them. And what I've always wondered with, in particular, serial killers, I don't know whether you know, there are people that murder a lot. What is the compulsion for them to do so? Is it that they just need it to satisfy, like as an example, me and you might go out to get a takeaway because it's something that we're craving. Is it the same kind of thing? I know it sounds a bit morbid to think of it like that, but it's what it is. It's severe illness, right? A lot of the time these people have, I'm assuming. So from your experience, why do they do it? Like, what is that compulsion for them to do so?
So I would say that serial killers are, you can fit them into different categories and they have different motivations. So it's not like one size fits all. So serial killers don't always have the same kind of thought processes or beliefs. You get some that literally do it for power and control. So these are sadistic people who like seeing their patients, not their patients, that's the wrong word, seeing their victims suffer. So they might have been subjected to horrific abuse, for example, as a child. So they might view every dynamic as there has to be a prey and a predator, and because I was the victim when I was a child, I need to be the predator. So that could be one motivation. Another one could be that they feel that they're on some sort of mission. So the victim represents somebody. So for example, if you've got a man who's like really unsuccessful in romantic relationships and has been rejected many, many times by women, and obviously he's got to have something wrong and a lack of empathy and all of that stuff as well. I'm just saying that in terms of previous experiences, then he hates all women, or maybe he hates people that reminds him of an abusive father. So he picks out targets that remind him of that person. So he feels like he's there to destroy that type of person. And then another motivation might be it's people who think they're on some sort of mission. So they believe that they're ridding the world of a certain type of person. So that might be, I don't know, drug addicts, or it might be certain ethnicities. So they're so bigoted in their views that they believe that they're doing like the world a favor. Obviously, I'm not saying that any of this is true, but this is in their mind. This is what they think they're doing. That's their motivation. And then finally, the rarest category, but the one that I'm the most interested in, would be people who have a mental illness. So people who have delusional beliefs, believing that they have to kill for some reason. So they're being controlled by God, or they're doing, God's work. I don't mean God's work as in they feel they're a superior race. I mean God's work as in God's actually talking to them because of their psychosis. Then that's another category as well. So yeah, so it's different things for different people.
Interesting. And I guess that leads on to like proportionally, like I've seen like famous people, for example, if P. Diddy recently, Jeffrey Epstein, Jimmy Savile, Al Fayed recently as well. Like famous high power people tend to proportionally do, bad things, whether it's, paedophilia or trafficking or, whatever it may be. Why do you think that is? Is it because they've got to a point where they could just, the normal just doesn't do it, like just having, maybe one partner with some kids, who just kind of get to the stage where they can do that as many times as they want, so they want to always take it to the next level. But why do you think that is? It's just interesting to me that, these things are all coming out, and as a proportion, it seems quite high that famous people do these things.
Yeah. I mean, obviously, like everything in life, we hear about the ones, or the media focuses on the ones that commit these kind of crimes. So I think they have to be a bit cautious in how we interpret that, because obviously there's many, many, many more celebrities they're not, sexual perverts and don't abuse their positions of power. I don't think that the fame causes this behavior. I think it enables this behavior, which is very different, right? So I think that they're already sexual perverts, or they're already, sexually attracted to children, or they're already quite misogynistic in their views. But the difference is they have the opportunity to do it. So if you take somebody like Jimmy Savile, that's a perfect example. If Jimmy Savile was Jimmy Savile but wasn't famous, he probably would offend, I think. But he probably would have only done it a couple of times, and then either he'd get scared of the police, or he'd get caught by the police and get arrested and put in prison. So he wouldn't have been prolific. But being who he is, firstly, he's got this access to victims. So, he was literally going around the country to hospital wards. So we got these young vulnerable women. He was on top of the pops, again, young vulnerable women, even boys. And he had this like aura of invincibility about him. He was friends with the constabulary, like the police loved him. He had connections with the royal family, so he's almost untouchable. So I suppose the point I'm trying to make is I think he was always those things, but he was just in a situation where he got to exploit other people. And again, people like Russell Brand, Tim Westwood's another one off the top of my head. They were like so Tim Westwood was like a gatekeeper to the music world. Russell Brand was seen as a bit of a Lothario. So again, I think the fame of having that attention in the first place allowed them access towards vulnerable women and towards fans who they manipulated. So again, I think it was in them. I don't think it was the fame. I think it was, so it wasn't the fame that caused it. I think the fame gave them access. And the other thing I'd say is that if you're already quite narcissistic and quite into yourself, and then you surround yourself by yes men because you're a multimillionaire music producer like P. Diddy was, or if you're, Russell Brand and you're always on TV, then it's easy, then nobody's there to check your behavior. So if a normal person said something that was a bit sexist or misogynistic or acted in a way that was inappropriate in front of other people, then the chances are they're going to get reprimanded, they're going to get told off. Whereas if you're mega famous, potentially mega rich and mega powerful, and you surround yourself with certain types of people, then they're either going to want to stay on your side because you pay them their money and they're part of your entourage, or you don't want to rock the boat because you're worried about the fact that they are so popular and so successful. So I think people don't check their behavior, and if it goes unchecked, then there's no feedback for them to stop. So they just become more and more emboldened.
Yeah, it's almost like the perfect storm, isn't it? In some cases, like, in particular Jimmy Savile one, that, I didn't know he was such good friends with the police. He literally had all the ingredients. And I suppose the next thing is how, not just with celebrities, but even with people who come to you, how do you rehabilitate these people or treat them? Sometimes like that story you mentioned about, the 18-year-old who committed murder and then eventually realised what she did was wrong. Like, what is that process like? Or what does it involve?
Yeah. It's a very slow process, the one thing I'd say. So we kind of touched on this a little bit before, but people who are on one end of the spectrum with a mental illness are much easier, in theory, to treat because you can medicate against symptoms. People on the other end of the spectrum who have just pure personality disorders, much harder. It takes years and years of therapy. But to answer your question, so the very first thing is you get the medication right. So if they have psychotic symptoms, if they are paranoid, if they are hearing voices, you get rid of those. As in the case of Yasmin, sometimes that in itself can take months, if not years, of very strong medications. You'll know as a GP that they have nasty side effects from, cardiac arrhythmias to weight gain to sedation. So they're not nice medicine. So you have to balance the quality of life and the side effects with the effects. And they often take weeks, if not months, to work. So that's the very first thing you do. And then you do the psychotherapy, which is done by the psychologists on our team. The one thing I'd say about forensic units, even though they are potentially quite volatile and dangerous places, they're very well resourced. So we have big teams, we have psychologists, we have occupational therapists and stuff.
Mm.
And so the therapy will look at general stuff like drug and alcohol rehabilitation, and also very individual therapy. So you go in microscopic detail over and over again of why they committed their crime. So was it, anger management? Was it something related to their past and trauma they've suffered that they're reenacting? Was it allowing themselves to be exposed to victims if it's, paedophilia, for example? So you look at exactly the risk factors and you try and decrease them. And then after that, and that in itself can take sometimes several years to go through that whole process. And then not after that, but whilst that's going on, you look at their behaviour on the ward. So again, it's not prison, but it's not, people come from prison. So there are beefs, there are problems, there are arguments, people invading each other's personal space. And if your patient's reacting badly to that, if they're getting into arguments and fights, then they're not ready to progress. If they're able to stay calm for 6 months, it depends on the psychiatrist. When I was heading up in the team, I would want to see my patients to have no incident at all for 6 months minimum. And then I'd start considering leave. And then when you do your leave, it has to be very structured. So you're not just walking out of the hospital and doing whatever you want. You have very short periods of leave. First of all, escorted, so with a nurse. And then if there's no problems, then unescorted for very short periods, 10, 15 minutes. If they come back in time, then you increase it to an hour, 2 hours. But there has to be a purpose. So that could be going to a job, going to college. You can have you can have leave for pleasure activities as well, like going to the cinema. But again, you literally bring back receipts to show that you were where you said you were. Internet cafes. And the other big thing that we do in forensic psychiatry units that unfortunately you don't get in general adult wards as much, you should get them in my opinion, but you don't, is occupational therapists. So we train the individuals up for some sort of occupation when they come out. Because if you're just leaving them, if they, not all, but a lot of my patients come in with very little levels of education. Some of them can barely read and write. And so we help them do their GCSEs. We help educate them whilst they're on the ward, or give them a vocation, whether that's, learning to become a barista, for example. And so when they get their leave, they go out to these workshops and to these places and volunteering shops, for example. So we instill with them the working life, basically, so that ideally when they leave, they've got structure.
What are the chances of these, say, for example, Yasmin, like you mentioned, what are the chances of people like that reoffending? Say they go through the rehab, say a couple of years, and then, the leave's okay, and then they're stable and they get discharged. There's always a risk of them, I guess, relapsing. But
Yeah,
what are the chances,
absolutely.
and how can that be mitigated? Because that, I guess, is potentially something quite important to think about, especially as it could lead to a very dangerous crime again.
Absolutely. I'll be absolutely blunt with you, Asif. Reoffending rate is depressingly high. It is something, depending on what metrics you use and where you are, it's somewhere between 20 to 30% of the people that we
Wow, really?
discharge from our service will come back in at some point. But number one, they were 100% dangerous when they came in. So to even get into our unit, almost by definition, there's a very, very high level of violence. So we're dealing with probably some of the hardest patient cohorts in definitely all of psychiatry, I'd argue, in all of medicine, actually, in terms of relapse. And the two biggest factors by far are when people stop taking their medication and when people take illicit drugs. So that's almost every case that I've seen of a relapse is in one of those contexts or both of those contexts. I'd be hard pressed to think of a case where it wasn't one of those two things. So in terms of them taking their medication, you can mitigate that by having a depot, which is, as you'll know, is like an injectable form of a medication. Again, it does come with its problems like side effects, but at least you know the individual's getting the chemical as long as they turn up to their appointments once a month or every 2 weeks. For the illicit drugs, that's much harder. I mean, you can do drug tests, and part of the condition sometimes of them being discharged is that they have regular drug tests. But as you'll know, you don't have the resources to do it, every week. You can only do it once a month, maybe. And if they want to, they can time when they're using their drugs. And also, people can deteriorate pretty quickly. So even if you see your CPN, your community psychiatric nurse, once a month, you could quite feasibly deteriorate quite quickly within that time. So it is hard. And part of it, as I said before, is the patient cohort so difficult. Part of it is a stretch of resources. So we don't have enough nurses and enough forensic psychiatrists to see everybody regularly. And so, there is definitely a risk of relapse, but it's something that we have a limited number of resources, and we have to spread it very thinly and try and make sure that we distribute them so that we're focusing on what we think are the most risky people.
I think this whole area is super interesting, not just from a fan point of view, but also from a medical point of view. And I think in another life, I think I would have done psychiatry. I actually came to a point where was it GP or psychiatry, But look, thank you so much. I've seen your stuff on social media, and honestly, it's so informative, interesting. It's probably one of the few doctor channels I actually learn stuff from. But what are your channels, or where can people kind of see you, find you if they want to learn more?
Thank you. That's very kind of you, Asif. So I have a YouTube channel. So if you just Google my name, I think the handle's at a Psych for Sore Minds, and I've got a TikTok channel as well, so you can find me on there. I've also got a book which outlines some of my most sort of interesting, fascinating and horrific cases. You can get that on Amazon. It's called In Two Minds. But yeah, thank you for having me on. It's been an absolute pleasure. I love talking about this kind of work.
Thank you so much. Thank you. Take care. Bye-bye.